Good afternoon to one and all. Thank you for listening to this lecture on an important topic which is close to my heart, uretropelvic junction obstruction versus non-obstructive dilatation, how to go about it. Hydronephrosis is an important cause of antenatal diagnosis, and among the causes, transient hydronephrosis, also known as non-obstructive dilatation, is the most common condition causing dilatation, and uretropelvic junction obstruction follows the second important cause of urinary tract dilatation. The Society of Fetal Urology grading actually started as early as 1993, and it got more established since 2010, where the grade 0 stands for normal kidneys, whereas grade 1 is mild dilatation of the pelvis, grade 2 dilatation of the pelvis and calyces, then further dilatation of the minor calyces, and then cortical thinning. The anteroposterior diameter classification of the renal pelvis was in vogue since 2001, and the measurement of the anteroposterior diameter is not always done properly. However, if measured, it gives a very uniform criteria, and in fetal life, in second trimester, less than 4 is normal, less than 7 in third trimester, and after birth, less than 10 is normal. It also helps on to grade the severity, and anything more than 10 in second trimester, more than 15 in third trimester, and more than 20 at birth is severe hydronephrosis. Now, the Fetal Society of Urology grading included only the morphology, whereas the later gradings like Bignon grading incorporated the APD also. So they included anteroposterior diameter more than 1.5 and the moderate cholestasis, and these are the ones where the resolution rate is very poor. Disadvantage of anteroposterior diameter is it's more of an operator dependent, and it is low in dehydrated infants. It is low in empty bladder, and it is also low in expiratory phase, and it is less ideally measured in supine position, and even risky in the presence of intrarenal pelvic configuration, where one will have more calyceal dilatation, whereas when there is more extrarenal bulging, then you will see a proper anteroposterior diameter increasing. Now, the UTD classification has been in vogue since the year 2014, and urinary tract dilatation classification involves antenatal as well as postnatal grading. Antenatal, there are 6 factors: anteroposterior diameter, calyceal dilatation, whether it is a central or peripheral calyceal dilatation, that division is also there. Then parenchymal thickness, parenchymal appearance, ureters, bladder, unexplained oligohydramnios. The same is applied in the postnatal period as well, where except the Likert status, 5 other parameters are there. So postnatal UTD, low risk P1 is only central calyceal dilatation 10 to 15, and more than 15 with the peripheral calyceal dilatation is P2, and parenchymal abnormalities are P3, and also the bladder and ureter abnormalities are also clubbed here. The pros and cons of urinary tract dilatation classification, it is simple to the radiologist, just to make sure that they don't miss out things. It is also easy to reassure parents in milder ones regarding the resolution. And it is also useful to do a referral, particularly in the Western world, where one can decide the extent of evaluation and then need for follow-up and the referral to the higher centers. On the other hand, when we deal with conditions in the tertiary centers, we still have to look at the fine print of the UTD report, because it includes a wide differential diagnosis of congenital anomalies, and the wide definition of UTD P3 fails to demonstrate accurately the severity of hydronephrosis. So this leads to misleads prompt treatment, and it does not suggest who needs a surgical treatment and who can safely be followed up. So the 3-year resolution rate was like 98% for SFU1 and 57% for SFU4, and the 3-year resolution was like 90% for UTD P1 and 71 for UTD P3. So this paper compared the old SFU grading and UTD grading, and felt that the UTD grading is slightly better in predicting the resolution. But when it comes to predicting the surgery, they are both the same. Now, Onan kept on improving the grading of hydronephrosis. He kept adding like parenchymal thickness, like whether it is a central or peripheral, and then where exactly the parenchymal thickness is there, whether it is in the poles or the periphery. So the Onan grading kept on improving in the way of the morphology. We looked at the fetal AP diameter, and then we found that more than 30 millimeter fetal diameter are the ones who definitely need surgery. And then we published this in the year 2010. Now, predictors for the need for surgery, the group from UPJO showed that the APD of more than 24 could predict the need for surgery with a sensitivity of 73% and a specificity of 88%. So they felt that in those less than 24, the burden of investigations can be minimized, but they didn't say that 24 millimeter is the one who needs surgery. Now, ultrasound criteria for the extent of antenatal hydronephrosis evaluation, we published this in the year 2018. Basically, we felt that in the absence of hydroureter, the VCUG had very little yield. And when the AP diameter was less than 20 millimeter, and the renogram had very little yield on obstruction. So probably less than 20 millimeter, I would wait for keeping on repeating the renograms. So this is our finding. So our current protocol is like this. When there is a boy with a bilateral hydronephrosis, obviously we will get an early VCUG to rule out a posterior valve. On the other hand, in those with more than 10 millimeter hydronephrosis, if the hydroureter is present, we'll go for VCUG. But if the hydroureter is absent, then if the APD is less than 20, we do the simple ultrasound follow-up. If the APD is more than 20 millimeter, we go for diuretic renogram. But here again, when there is a calyceal dilatation or cortical thinning in a 15 to 20 millimeter hydronephrosis, then one may go for a diuretic renogram. So this is a typical PUJ obstruction where the diameter has become 25 to 30 millimeter during the follow-up. Calyces are dilated, cortex are thinned, showing that it is progressing from 3 to 4. And in the renogram, there is a drop in split renal function. There's an obstructed curve. T-half is not available, prolonged transit time, hold up in delayed films. So these are all typical cases where you can easily come to a conclusion. And this is another case where there is a typical non-obstructive dilatation where although there is a hold up in the delayed films, there is drainage of the tracer and the function is preserved. So reduced parenchymal function and query obstruction they have reported, but I would still wait in this case of it's a typical non-obstructive dilatation. Now, the why we need to know all these details is because we looked at the functional outcomes of early versus delayed pyeloplasty, and we found that early pyeloplasty in prenatally diagnosed SFU grade 3 to 4 obstruction leads to significant improvement in renal function. So we need to pick up cases where we can actually offer a recovery. Whereas if we keep on delaying for functional loss, particularly in grade 4 hydronephrosis, and then that loss may not be reversible. For example, here early pyeloplasty, there is an improvement in function. In late pyeloplasty, there is a moderate improvement, but compared to the original function when it was lost, it didn't come back to the original level. So this is what we came up and published. And can you predict which case will lose function during the follow-up and preempt pyeloplasty to prevent a permanent loss? So this is $1 million question all of us have been asking. And one of the parameters we published in the year 2010 was pelvis cortex ratio as a sonographic marker of uretropelvic junction obstruction in children. So we combined the pelvis size and then cortical thickness, and we felt that if the pelvis cortex ratio is more than 12, then all of them needed the pyeloplasty. Whereas if it is less than 8, none of them needed pyeloplasty, and the 8 to 12 are the ones who need a close follow-up. We also published this hydronephrosis severity score in the year 2018. This basically combines ultrasound and renographic parameters. In the ultrasound, we looked at both SFU and APD grading, then drainage pattern, as well as differential renal function. And then when we combined, the maximum score was 12. And 9 to 12 is a severe hydronephrosis. So we have this SFU grading, which already is graded from 0 to 4. We also added the APD characteristics. So anything more than 20 becomes a grade 3, and more than 30 becomes grade 4. And then we also look at drainage pattern, and normal drainage is like this. The drainage pattern score 1 is given when there is a drainage after furosemide, then sluggish drainage, no drainage, and outgoing curve with covers film showing static state. Then differential renal function, we gave a grade of like this 0 to 4, more than 40% is 0, and less than 30% is 4. So we found that when the hydronephrosis grade is severe, like 9 to 12, then all of them needed surgery. So hydronephrosis severity score could be a useful tool to predict the need for surgery, and a deterioration was noted in those with a score more than 9. So if all these parameters are there already, then you can say that one will eventually lose function. So other ultrasound markers, resistive index, and which is a peak systolic velocity minus end diastolic velocity by peak systolic velocity. If it is more than 0.7, and there are reports which says that there is suggestive of obstruction. Then elastography has been used, and then it is the shear wave velocity is more in those with UPJO than the non-obstructive dilatation. We published this from our institute there. Other renographic markers, T-half more than 20. Is it always suggestive of obstruction? That is another $1 million question. Then intrarenal transit time more than 3 minutes. Is that suggestive of obstruction? That is another thing which has been published widely. And then late films hold up to at a 2-hour film. Is it suggestive of obstruction? So these are other markers. So here I'm showing this 3-month-old baby with this hydronephrosis, which is 15 millimeter. Then it has now progressed to 18 millimeter. There is some calyceal dilatation, but the cortex is still not affected. Now, when we sent the patient for a renogram, they have reported that normally functioning right kidney with obstruction at a PUJ level. So the function has not dropped, but they have reported it as obstruction. But when you look at the renogram, there is some drainage happening at a later stages here. So it is not like completely obstructed. And on the other hand, when you look at the T-half is definitely more than 20, but even on the left side, it is more than 20. So anything more than 20, you can't really say that that is really obstructed. Now here, this is another film of the same patient, which shows that individual images here, the 1 minute frames. And you can see that the cortical transit time is something like 3 to 4 minutes. So it has started appearing very early there. But there is some hold up in the late film. And then the curve looks like it is draining. So what is it? Is it an uretropelvic junction obstruction, or can you wait? I suppose I'll wait in this particular patient and then repeat the studies in 6 months' time. So the problems with this kind of situations is these children undergo a repeated invasive imaging with renogram, ultrasonogram to differentiate non-obstructive dilatation and uretropelvic junction obstruction. So what about the role of urinary biomarkers? Do we have any established markers, or can it be another parameter which can be used? So we looked at accuracy of urinary biomarkers in differentiation of uretropelvic junction obstruction from non-obstructive dilatation in children. And we found that there are 6 biomarker candidates which are really useful, out of which neutrophil gelatinase, the lipocalin, is the top performer with an accuracy of 77%, followed by monocyte chemotactic protein and kidney injury molecule. And then we have the CA19-9, EF, and IP10. So we found that among all the markers, the CA19, Kim, and NGAL were some of the best markers. Maybe if we combined 3 biomarkers with a panel of biomarkers, we can say that they are indicative of someone which is going to deteriorate or already deteriorating. Now, this is a paper which was published from Colorado, surgical decision making in infants with suspected uretropelvic junction obstruction, and the stakeholders' perspective. Whenever the treatment decision was made, it's mostly the surgeon's recommendations and then the parental preferences. So they rely a lot on the surgeons and then the physicians' experience as well as knowledge in coming to a conclusion. So when so much of weight is put on us, it is prudent on our part to update our knowledge and then make sure that we are following the latest evidence-based medicine to pick up these cases and then offer them a treatment before the function is lost beyond recovery. So thank you for listening to this talk.